Okay, well, thank you everyone for coming. I hope everyone can hear and see me. If you can't, please let us know. You can use the question box there to notify us, and we can see what we can do. A few housekeeping things. In about an hour or so, you will get an email with your CE certificate. So just watch for the email. You don't have to contact us. It'll automatically be sent to you. There will be a brief survey at the end, if you don't mind, to fill that out for us to provide feedback, just to let us know sort of how you like the topic, the presentation. If you have suggestions for future topics, feel free to announce that there for us as well. You may submit questions along the way during the presentation that we'll either answer along the way or most likely at the end. We'll save some time in the last 5-10 minutes to go through the most relevant of those questions. If it's a question that maybe doesn't pertain to the whole group, we might contact you by email to provide an answer for you. But overall, my name is Nick DePompa. I'm one of the neurologists at Southeast Veterinary Neurology. It's my pleasure to visit with you this afternoon to review Canine Chiari-Like Malformation and its association with neuropathic pain, two of my primary areas of interest. And so just a brief outline of what we'll cover. So we're going to go through kind of the pain pathway in a relatively concise way and just discuss sort of the types of pain and sort of some of our targets for pain therapeutics. And then we'll move into Canine Chiari-Like Malformation. We'll discuss that syndrome, both the primary abnormalities of Canine Chiari-Like Malformation, but also the secondary and sometimes associated abnormalities. We'll briefly discuss the grading schemes, both for Chiari-Like Malformation and the sort of secondary abnormality associated with it, which is of great clinical relevance, which is Syringomyelia. A bit about the pathogenesis, or at least the suspected pathogenesis of Syringomyelia. Discuss sort of the commonly affected breeds, their common symptoms, and different treatment and prognoses information. So first, starting with the pain pathway, we'll go through two different diagrams. So this initial diagram is a relatively cartoon version, but it does capture some important points. So if we look at this cartoon gentleman here and start with his left foot here, he's got a site of injury there. So something happened, he stubbed his toe, whatever the case may be. And there's going to be a local sort of inflammatory reaction, but also potentially pressure and other sort of mechanical forces that were enacted upon his toe. That information initially is sort of an external force, right? So there's the injury or temperature change depending on what the type of injury was. That information first needs to be sort of transmitted into an action potential to truly become a neurologic phenomenon. And so that will happen locally and then travel up the afferent nerve of his peripheral nervous system, so nerves going up his leg, to his spinal cord. And if we look at sort of the portion of the diagram labeled number 2 here, that's the representative segment of the spinal cord where that information is coming up that afferent nerve through the dorsal root ganglion here to that dorsal horn of the spinal cord. Most of that information is going to cross over to the contralateral side of the spinal cord, and that information will then ascend up primarily through the spinothalamic tracts. Then that information, most importantly, is going to arrive at the brain. So that information is going to pass through the brain stem, as shown in sort of the third item on the illustration. And then once we get up to about the thalamus, that information is going to synapse again and go up to the somatary sensory cortex. And so that's where that actual sort of initial physical injury will then become something that's actually perceived by the individual or by the patient. This next diagram shows that same thing just in a little bit of a deeper sort of illustration. And it goes through sort of the 5 steps associated with an injury or illness resulting in perceived discomfort, meaning that patient consciously recognizes that there's a noxious stimulus that has resulted in an unfavorable sort of sensation. And so if we start down in this equine example, but it's quite similar across species, transduction is that first step. So that's going to be where the initial injury or disease that's going to result in this eventually perceived noxious stimulus. And ultimately that response is a chemical injury initially, but it needs to become an electrical impulse in order for it to make its way to the brain. And so that first step of that sort of either thermal, temperature, et cetera, which is essentially more or less a cellular phenomenon, but that's not yet an electrical phenomenon. And so that transition there to that electrical activity is transduction, which is the first step. That information is then going to be transmitted along the sensory peripheral nerve, so that's the transmission phase, in order to get to the spinal cord. And so similar to the last diagram, if we follow sort of along here where it says transmission in the left sort of pelvic limb of this horse, that's the information still within a peripheral nerve going through the dorsal root ganglion, which is the small bleb here, and then passing into the dorsal part of the spinal cord, synapsing on an inner neuron, and then synapsing again, crossing over to the contralateral side where it's then going to ascend, again, primarily through the spinothalamic tracts. The travel of that impulse through the spinal cord is the projection phase, and that's projecting essentially that electrical impulse up to the brain where it will ultimately be perceived for the perception phase. If at any point along this way that information doesn't continue along this path, then it's never going to be perceived by the patient as a noxious or unpleasant stimulus or painful stimulus. And that's where a lot of our targets, both the innate sort of targets within the body and then those that we manipulate through pharmaceuticals, can intervene to modulate that response. And so the body naturally does that to a certain degree with endogenous or opiates and things along, or opioids rather, along those lines. But then also our drugs work on some of those same targets to modulate that information, both at the spinal cord level and to a certain degree at the brain level. Those same targets, though, can work against us when it comes to peripheral and central sensitization. So if there is a truly neuropathic form of pain or a source of pain that is chronic enough that the body starts to not handle this projection through the normal mechanism, ultimately the body starts to have a decreased pain threshold. So something that may no longer need to impart a perceived level of pain that's significant may start to do that through sort of this mechanism of sensitization, which we'll talk a bit more about here in a minute. When we look at the different types of pain, there's a lot of different ways to classify pain. And we haven't done this quite as well in veterinary medicine, but certainly if we extrapolate from the human literature, there's a number of different ways to classify pain. And it is important to have at least a brief sense of these classifications because it does affect our overall ability to make choices for our patients with regards to how to best manage their pain. So the two sort of stratification systems that I prefer the most, keeping things relatively simple, are classifying pain with regards to the duration of the pain. So there's both acute forms of pain and obviously chronic forms of pain. That definition of that timeline, acute versus chronic, in human patients is relatively worked out where that sort of theoretic sort of line in the sand is drawn. In veterinary patients, there's not a firm definition of acute versus chronic as it regards to pain, but it's important to think about sort of the duration of that pain. The second sort of way of classifying pain is with regards to the cause. So for nociceptive pain, that's the normal response to tissue damage. So it's something that should cause pain, like a surgical procedure, for an example. Or if the patient is injured and they fall and break their leg, well, that is supposed to be painful. That's a normal sort of mechanism of our body to let us know that that tissue damage is occurring. And so that's the easiest definition of nociceptive pain. When we talk about neuropathic pain, that's really when pain becomes malignant, if you will. And so that's when the body is no longer normally processing that sensory input. It's mostly talked about in the central nervous system, but certainly occurs to a lesser degree in the peripheral nervous system, where there's an abnormal processing of that input, and that ultimately is going to lower the pain threshold. And that's commonly seen with chronic pain, which is why patients that have been painful for an extended period of time, even if we relieve the underlying cause of their pain, they can still be painful for a period of time at a level that's unexpected for the remaining stimulus. There's a number of different sort of studies and different papers that have put out sort of what our approach to pain management should be. They all really are saying the same thing. I like the very simple one from AHA. They use PLATTER as sort of the acronym, but essentially it's plan for the pain if you can. Obviously, there's types of pain that we aren't going to know that injury is going to occur and therefore can't plan for it. But in the case of surgical pain or other sort of inflicted pain, we can plan for that. Anticipating not just that there will be pain, but what is the source and type of pain? So is it inflammation that we're addressing? Is it an actual burn or other thermal type injury, etc.? And then treating the pain, but then most importantly, coming back and reevaluating our success at managing that pain and returning to the top, meaning do we kind of reassess this periodically? Depending on the type of pain, the chronicity of the pain, what types of drugs we're using, we obviously need to kind of return and reevaluate our approach if we're not getting the intended results. And certainly a lot of that is with medicine. So, just a very brief chart. It doesn't encompass all pain management modalities, but on that left column, we have the pharmacologic interventions. So things that, all of you are likely familiar with: steroids or NSAIDs, opioids. Examples in the opioid category, obviously there's short and long-term, meaning things like fentanyl versus buprenorphine, etc. NMDA antagonists, so the one that people are most familiar with is ketamine. Obviously has a very short half-life, so not necessarily going to be a great long-term use drug, but we have things like amantadine, which are oral sort of equivalents that can be used for long-term pain management. MAO reuptake inhibitors do have a place in chronic pain. Calcium and sodium channel blockers, so a lot of our local blocking agents, as well as things like gabapentin and to a lesser degree amantadine. Pregabalin is also in that calcium channel blockade category. And then alpha-2 adrenergics, things like dextromethorphan, for example. In the second column, we have sort of the non-pharmacologics, which need to be considered equally strongly in coming up with a plan, with the absolute most important being resolving the source of pain. So sure, we can manage the symptom of pain with medications and other modalities, but if we have the ability to address what's causing the pain, that overall is going to be a longer term, more successful longer term strategy. Other things that are not always included in pain discussions, but more and more are being factored in, are some of the physical modalities, things like acupuncture, physical therapy, therapeutic laser, even myofascial release, which certainly human medicine has been doing that for a lot longer than us. And more that's being discussed and added to a multimodal sort of pain therapy protocol for veterinary patients, as it should be in certain circumstances. So again, keeping in mind what the underlying disease process is and whether or not there's any imparted risk by adding these. And then environmental enrichment is one that I add. So obviously a somewhat difficult thing to evaluate in veterinary patients, but more and more on the human side, there's a suggestion that obviously our anxiety level does have a great role in our perception of discomfort. So a patient who has the same degree of physical injury or disease causing discomfort, the patient who's in a highly anxious environment or is naturally a highly anxious person is going to have a much more painful experience, at least their perception of such, which is certainly real. So environmental enrichment, what I mean by that is obviously controlling sort of the overall mental well-being of that patient through enriching their environment. So I'm a bit obsessed with black and tan Dachshunds. So as we get started here, we're going to watch Caruso, a very famous black and tan Dachshund, take off for us. All right, so now back to the real stuff. So this is a Cavi. You can see she's just on a leash here, which does touch her neck. And then as she walks, just watch how distracted she seems to be and how she frequently stops to sort of scratch in an incessant fashion. So there's no real external stimulus here, although she does have a neck lead on, which could be providing some tactile stimulus, but she'll actually do this same thing even without the leash. And so her owner's primary complaint was They couldn't take her on walks anymore because she had to constantly stop and scratch. But when she's stopping to scratch, she's not always making contact. So she's just kind of kicking that back leg, and obviously something is upsetting her, distracting her, or there's some stimulus that she's feeling that's causing her to do that, but maybe not the most classic sort of itchy dog, but an owner may not be able to make that distinction. So when you look at that dog, kind of consider some differentials for her. So obviously an itchy dog, we think about things like atopy, food allergy, flea allergy, maybe even ear infections because it is a cavy after all. Sometimes dental disease, if they're kind of scratching more towards their face, people think about periodontal disease. But by far and away for this cavity with that type of presentation, the most likely cause is going to be Chiari-like malformation and the secondary Syringomyelia, which we'll define all of that here in a minute. And certainly there's no paper that suggests this, but my strong feeling is that it's probably the top either misdiagnosed or underdiagnosed neurologic condition in veterinary medicine. Because for good reason, the first line care provider is going to be thinking about the common things. With common things happening commonly, you're going to think about all of your skin disorders, ear disorders, dental disease, etc. As we should. We need to rule those things out. But if we're not getting resolution and it's an at-risk breed, we should certainly be thinking about some of these maybe less common, but actually quite common causes, which are Canine Chiari-Like Malformation and the associated Syringomyelia, which is what we'll spend the rest of our time chatting about. It is something that occurs in humans as well. Throughout the lecture, I'll kind of bounce back and forth a little bit, drawing some parallels between what we do in veterinary medicine and our understanding of the disease and management of the disease, and relate sort of how that compares to the human side. But it's a condition that's been described in humans for a very, very long time. It got its name from the Austrian and German pathologists who first described it. In humans, there are very distinct subtypes of this condition. The version that our patients get, canine patients get, is most similar to the type 1 that is described in humans. Some literature that sort of went through a phase where we called it caudal occipital malformation syndrome. So Chiari-like malformation and COMS are often used interchangeably, at least in some of the older literature. So who does it affect? For once in a neuro lecture, not the Dachshund, at least not commonly. The top breeds are going to be toy breeds, though, with the Cavalier King Charles Spaniel being sort of the poster child for the condition. Brussels Griffon are not too far behind, although they're just a slightly less popular breed, at least in this geographic region, but their incidence of it is reasonably high within the breed. Other toy breeds, the smaller size poodles, Yorkies, Pekingese, etc. Don't take that list as all-encompassing. So certainly this can occur in other breeds as well, even rarely in large breed dogs, but the vast majority of these are going to be cavies and Brussels. Take-home point is Cavalier King Charles Spaniel. This needs to be on the differential list, almost regardless of whether they even have symptoms. The clinical presentation and the significance does seem to vary among breeds, meaning there are some breeds where this is a lot more likely to be incidental without causing any overt symptoms. Also, what symptoms they develop do vary a little bit between breeds. So how common is this condition in cavies? And a lot of the literature that we're going to cite here to get some statistics are going to be based off of cavies just because they are the poster child, so it's easy to sort of study them. Overall, a couple of different papers, but somewhere between 91 and 95% of Cavaliers are going to have the Chiari-like malformation. I'm going to show you exactly what that means, but that's the bony malformation at the caudal aspect of their skull. That doesn't mean that they will have or are going to have Syringomyelia, which is the fluid dilation which will develop within the spinal cord, which I'll also show you here in a moment. But at least in these couple of studies, greater than 90% of the affected cavies had Chiari-like malformation, and then of those, somewhere between 45 and 70% had Syringomyelia. So a large number, almost all cavies essentially, have Chiari-like malformation, and then a pretty significant portion of those dogs go on to develop Syringomyelia, which is the most important sort of secondary pathology from the Chiari-like malformation, because the Syringomyelia is actually what causes, or at least what we suspect to be the bulk of the cause of the symptoms, although it is certainly multifactorial. There is one paper looking at the inheritance within cavies. Obviously, they're a relatively inbred and closely bred breed, and so they are prone to congenital genetic disorders. There's a long list of them, but this paper showed that in cavies, this is a genetic disorder. It does have a complex inheritance, but it's nonetheless a congenital problem that is indeed genetic within the breed. What might the clinical signs be? So the most common thing on physical exam, meaning if they present to you for an exam, is going to be mild to moderate neck pain. So most of these dogs, even if it's not what they're presenting to you for, if it's a cavie, if they have Chiari-like malformation and the associated Syringomyelia, the odds of you finding at least a bit of neck pain on palpation is quite high. The number one thing that owners are going to notice is scratching. So they might be presenting to you for pruritus, and obviously those common things need to be ruled out, but have this in the back of your mind for sure. So kind of exam finding wise, neck pain is likely the most common thing. Presenting complaint from an owner, it's more so the scratching or sort of phantom scratching where they're incessantly scratching, but may or may not even be making contact with their neck or ears or shoulder. Sometimes they'll do kind of just like an air guitar type kicking of their pelvic limbs without even making contact. Later in the course of the disease, there are definitely other neurologic deficits that may be noted either by the owner or by the practitioner. They certainly can develop a para or tetraparesis, so a weakness in some or all of the limbs, an ataxia where their foot placement's not normal and they seem to not have a great sense of where their limbs are in space, resulting in an ataxic gait. In relatively advanced cases, they can develop scoliosis, and it's easiest to identify if you actually just look down, have them on the floor, look down from the top, and you'll see that their spine takes sort of almost like an S-like shape. Some owners will also notice that they feel like their head is being held a bit off to one side. Other things in some papers and more so in textbooks that might be listed as possible clinical signs are deafness, facial nerve paralysis, and seizures. I've lumped these into one bullet point and put controversial because likely, in my opinion, these are not directly related to Chiari-like malformation or even the secondary Syringomyelia, because there's alternate explanations for each of these. Certainly, deafness and seizures are often, the seizures being idiopathic epilepsy in most cases, are common disorders in cavies as well. So if cavies are prone to these things as well, well, sure, just because we diagnose Chiari-like malformation like 90% of cavies might have, and it doesn't mean that any other deficit we can lump together with that finding. They're allowed to have more than one problem. So certainly paresis, ataxia, scoliosis, scratching or phantom scratching, and neck or facial pain could easily be caused by this condition. Those last couple of items there, I would think real hard about whether we lump that together versus considering sort of alternate diagnoses for those. So another video here, and one thing to pay attention to is watch how this patient begins to scratch incessantly when the stimulus is our nurse kind of touching or scratching her neck, which is certainly true for some of these cavies where they'll have an area when you touch their neck, that tactile stimulus results in this sort of manic episode of phantom scratching. And a lot of owners will notice this when they go to take these patients for a walk. If they put their collar on, that tactile stimulus there about the neck might touch their sensitive spot and result in this, limiting the ability for them to go on their walks without taking frequent stops to stretch. Overall, these patients do better wearing a harness in most cases. So how do we diagnose this condition? It's a combination both of signalment, so their age, their breed, their history. So what owners, are self-reporting as the symptoms and clinical signs that they're noticing at home. What are you finding on your examination? And then an MRI is obviously the definitive way to achieve a diagnosis. And this is an MRI of both the brain and the cervical spine at a minimum. There are two distinct sort of goals that need to be met in order to make the diagnosis. So obviously we need to identify Chiari-like malformation and or Syringomyelia on the imaging. But equally important, we need to rule out other possible causes. So just because the patient has neck pain and we find Chiari-like malformation and or Syringomyelia, we can't assume that that's the cause of those symptoms, because certainly there's many other things that can cause those same symptoms, the relatively vague symptoms. So for that reason, we need a test that will also rule out the other potential causes at a relatively high rate. An MRI tends to be by far and away the best single test to rule in and out Chiari-like malformation and rule in and out the secondary comorbidities and other unrelated diseases which could be causing the same symptoms. What I mean by that is, could we have a cavi who has Chiari that's incidental, not causing symptoms? They develop neck pain and it's because they have intervertebral disc disease or meningoencephalitis or other unrelated diseases. So we need to both prove that they have this condition and rule out other reasonable differentials. You can see to a certain degree Chiari-like malformation and Syringomyelia with a CT. It does have a much lower sensitivity, but even more important than that, it's much more likely to overlook some of the other either comorbidities or other diseases which may even be more pressing for that particular patient if they were to be missed. Myelography is profoundly contraindicated in patients who are suspected to have Syringomyelia, as very often it will result in at least temporary, if not permanent, neurologic decline. So what is Chiari-like malformation characterized by? So there's a few characteristic traits that we look for to diagnose Chiari-like malformation, and then we'll go through the traits for diagnosing Syringomyelia. So here we've got two images side by side. So on the left panel, you've got an affected MRI. So it's a T2 weighted image, and it's a sagittal, meaning the patient is looking to the left of the screen and you're viewing sort of at a 90-degree angle. So we have the patient's brain here, and then the first couple segments of their cervical spinal cord here. The next image just to the right of that, it's a similar MRI image. The positioning is maybe a tiny bit different, but it's also a T2 sagittal image of a normal patient. So on the left, we have an affected patient. On the right, we have a normal patient. So we'll go through and we'll use these same two images to demonstrate the different characteristics for both the CM component and the SM component. So the first is hypoplasia of the occipital bone, which results in a crowding of the caudal fossa. So the caudal fossa is going to be this region here, the very caudal aspect of the brain. The occipital bone is that very thin bone that travels just caudal, just behind the cerebellum. And so in most Chiari-like malformation patients, that bone's relatively underdeveloped. It doesn't come as ventral as it should, and it indents cranially before it should. So on that image, you'll see that the bone sort of tapers in, pushing the cerebellum forward at about the mid-cerebellum, as compared to the image on the right where the occipital bone comes all the way down, so it kind of cups the back of the cerebellum without indenting it prematurely. If we look at sort of in the affected patient on the left, how that occipital bone being hypo and dysplastic pushes upon the cerebellum prematurely before coming all the way down ventrally, it results in the vermis of the cerebellum here kind of pooching out towards the foramen magnum, which is the next sort of classic thing that we need to look for to say that we have this diagnosis. So you have that hypo and dysplasia of the occipital bone resulting in the cerebellar vermis extending towards the foramen magnum. Additionally, you'll note in most cases that there's an obliteration of the dorsal subarachnoid space. So since this is a T2 weighted image, fluid content or tissues with a high fluid content or fluids themselves will be very hyper intense or essentially more white. So if we look along the top of this patient's neck, there's a big white sort of strap here that's going to be subcutaneous fat. If we look within the brain in the ventricle here, in the lateral ventricle, it looks white because, again, that's fluid. And so that spinal fluid that is produced there by the lateral ventricle is going to pass through, coming here to the third and fourth ventricle, and then it needs to exit to a certain degree through this dorsal subarachnoid space, which is the space between the cerebellum and the junction between the brainstem and the first cervical segment. In patients that have Chiari-like malformation, you won't see as clear of a hyperintense linear line passing through there because that fluid is at least partially obstructed as it exits through the foramen magnum. So again, if we look at our normal patient on the right, you can very clearly follow that fluid path, whereas in the affected patient, maybe there's a small streak of hyperintensity passing through there, but it's certainly obliterated as compared to a normal patient. The fourth criteria is kinking of the medulla. So the medulla is this caudal portion of the brainstem. So if we look in our affected patient, the medulla being here, if we just kind of follow it from kind of the pons, the medulla, and up through the first cervical segments, it almost takes sort of a sigmoid type shape, or at least the C part of that sigmoid shape, where it looks sort of like it comes down and then bounces back up to get to the cervical spine, as compared to being much more of a linear path in the more normal patient. And that's called medullary kinking. And that's one of the things that we expect to see if we're going to make the diagnosis on MRI of Chiari-like malformation. Other pathologies that are equally important, if not more important. Syringomyelia by far is the most important take-home with regards to these pathologies. Syringomyelia is a fluid accumulation within the spinal cord. And so on this image, this is also similar T2 weighted sagittal image. And you can see through the cervical spinal cord here that there's this sort of hyper-intense lobulated region within the parenchyma of the spinal cord. And that's the syringomyelia, which for a lot of patients we think is an important prerequisite to symptoms. Not in all patients, meaning you can have symptoms with Chiari-like malformation alone, but equally, if not more importantly, the Chiari-like malformation resulting in the syringomyelia is an important step because the syringomyelia results in the bulk of the symptoms, we believe. With regards to syringomyelia, because it's so important, there is a definition that Claire Rusbridge provided to us in 2017, which is where the normal central canal, so there is a small streak of spinal fluid that you will see there on the image in a normal dog. If it's greater than 2 millimeters, it's defined as a syringomyelia. So very small region there, it can be a version of normal, which we just call the central canal. If though that region is dilated greater than 2 millimeters, then we suspect that to be syringomyelia. The location of syringomyelia is also important because it affects how we screen these patients, both with preventative screening, but also through diagnostic screening to determine if they are affected. And so in one paper looking at 49 cavies, all affected dogs with syringomyelia had it within their C1 to C4 spine, meaning for many it continued further than that. 76% or so it continued through their thoracic spine, 50% of those it continued from their neck all the way down to their lumbar spine. But all of them that had syringomyelia from Chiari-like malformation had it present in the C1 to C4 region, meaning if you were not going to MRI the entire spine and you wanted to look one place to make sure that it's present to make that diagnosis, the neck is the best place, meaning you wouldn't want to screen patients by looking at their thoracolumbar or lumbar spine unless they had symptoms that fit there, in which case I would recommend imaging their entire spine. But if you were going to do a screen looking for Chiari-like malformation at the base of the skull and syringomyelia, a brain and C-spine study is going to give you the highest chance of picking that up. Important tidbits: the size of the syrinx does positively correlate with age, meaning it gets worse with age, or at least gets larger with age. The size of the syrinx does not always directly correlate to the degree of pain. So there are some patients that have minimal symptoms with a very large syrinx, and other dogs with a very small syrinx that have quite significant symptoms. There is thought to a more asymmetric syrinx being likely to cause more discomfort than a perfectly round, perfectly symmetric syrinx. Real quickly, other secondary pathologies. So some of these patients will have a dilation of their quadrigeminal region, sort of an intracranial arachnoid diverticula. On this image here, this is the third ventricle here. There's a normal sort of very slit-like potential space that lives here. And in dogs that have sort of a dilation of this region, you'll see more fluid there, just like in this example. Often we don't associate that, at least in these patients, it's relatively mild. We don't associate it with a lot of symptomology, but it's certainly something that you'll notice to a greater degree in these patients. Likewise, their ventricles overall tend to be a little bit larger than a similarly sized dog that doesn't have this condition. The implications of that are unclear. They're definitely nothing like hydrocephalic patients where we suspect that the large ventricles is actually causing symptoms. It's not the case here, but you will notice that the ventricles are a bit enlarged as compared to a similarly sized dog. This image that I borrowed kind of puts all of those things together. So it's a similar brain and C-spine MRI. It's a T2 image. You're viewing it from the side as it's the mid-sagittal. And it just shows all of those components together. So the enlarged ventricles, the increased flexure or quote unquote kinking of the medulla, that underdeveloped and dysplastic occipital bone, the resultant sort of herniation of the cerebellar vermis towards the foramen magnum, and then the bright hyperintense region sort of centered here between C1 and C2 is the syrinx or syringomyelia. And then a lot of times around it, we'll see sort of this penumbra of not as hyperintense, but more hyperintense than normal spinal tissue that we suspect to be pre-syrinx. And if you MRI those patients again in the future, often that pre-syrinx region does seem to develop into a true cavitary region like a true syringomyelia. We won't spend too much time on this, but I included it for completeness just because there is frequent confusion. Atlanto-occipital overlap is a completely different syndrome. It's not part of Chiari and syringomyelia. It sometimes can be seen hand in hand, meaning the Yorkies in particular do tend to have atlanto-occipital overlap, often with atlantoaxial subluxation, and they will have a certain degree of Chiari-like malformation and syringomyelia, but they're not the same syndrome. They do need to be addressed, meaning we need to address both conditions if they have it. Depending on the patient, the degree of effectiveness, there's obviously many variables to that statement, but it's important to not diagnose Chiari-like malformation if the patient truly only has atlanto-occipital overlap. And even some radiologists will not make that distinction very clear. This is a similar MRI image. And so kind of between the arrows A and D, that sort of curvilinear kind of black or hypointense region is the roof of C1. So it's the dorsal process, or dorsal lamina rather, of C1. And you can see it's sitting much more forward. It's sort of tilted and extending more cranial towards the brain. So it's actually located in the foramen magnum as opposed to being just caudal to it. This patient likely also has an atlantoaxial subluxation. So the dens, which is item C, is pushing up from the bottom. One can't look at this and say that this is Chiari because that compression is not from a dysplastic occipital bone. It's from C1 extending into the foramen magnum. Both conditions can cause a syrinx, but they are distinctly different syndromes. Now I've put a 3D reconstruction of a CT next to it to demonstrate sort of the bony aspects. Obviously, this is a CT, so you don't see the soft tissue very well, but you see the bones very nicely. And so in sort of item A there at the end of the arrow, you'll see C1 is sitting sort of a bit dorsally displaced and rotated and kind of pushing cranially into the foramen magnum. Label C is the dens of C2, which is sitting up higher than it should. Again, that syndrome, though, is not truly related to Chiari-like malformation, but in certain breeds, particularly the Yorkie, they're going to go hand in hand. So we need to diagnose both of them because there are implications with regards to treatment. The British Association has put together a grading scheme. I've put the concise version of it here for you to review, but essentially they grade both the Chiari-like malformation and the syrinx development separately. The Chiari-like malformation is truly just based on the degree of indentation of the occipital bone and how much it's impacting and causing herniation of the cerebellum. Whereas the syrinx in table 2 is graded based both using the actual size of the syrinx, meaning the width of it, not necessarily the length of it, but the width of the syrinx. But it also has a component of age factored in. And this is used to help develop breeding strategies and determine sort of which cavies are appropriate mates to decrease the odds of passing this condition along. So how does Chiari-like malformation lead to syringomyelia? It's a complicated question that there's not a definitive, straightforward answer to. It certainly has to do with a change in the cerebrospinal fluid dynamics. Presumably because of that obstruction, it's going to change both the laminar flow of the spinal fluid as it exits the foramen magnum, but also the velocity, the degree of turbulence, etc., will all be affected, as well as there will be a greater change in the pressure profile as it exits through that region. And all of those things likely relate to the development of the syrinx. Quick slide just to say that this occurs in Brussels Griffons as well at a very, very high incidence, with 65% of the dogs in this particular study having Chiari-like malformation, and then half to 3/4 of those also having syringomyelia. Again, this was a group of AKC registered, supposedly healthy, well-bred Brussels, not dogs that were presenting for a problem. So even in this quote unquote healthy population, the incidence was quite high. So what do we do about this? There are medical therapy options, and they're largely symptomatic, meaning pain medications to manage discomfort if that's a big factor for that patient. In some cases, anti-inflammatories, whether it's a low tapering course of steroids or an NSAID, obviously not both. Spinal fluid reduction is also a long-term strategy. Using a proton pump inhibitor, essentially omeprazole, also known as Prilosec, at least here in the States, does decrease the amount of spinal fluid that's produced by up to 30%. So by having less spinal fluid produced, the thought is there'll be a greater reduction in how much fluid has to pass through the obstruction, therefore reducing the pressure profile changes and the degree of turbulence and such that might be experienced by the spinal fluid as it exits. It is thought to slow the rate of the syrinx development, but probably isn't going to stop its progression. There's not a ton of good studies looking at the prognosis of medical management. We'll look at a couple here briefly. I've included for you to review later just a couple of slides here looking at different pain medications and their associated mechanisms. So obviously anti-inflammatories, whether it's steroid versus non-steroidal, depends on what disease we're treating, the patient's other health and comorbidity issues. Obviously being careful that we don't mix and match the steroid and non-steroidals or switch back and forth between a bunch of different non-steroidals. So obviously using caution. Obviously our opioids, there's a long list of them. Some very short acting, some better for longer term use. I've listed them here with some durations, dose route, etc., that you can review at your leisure in the future. Other ones that people are less familiar with, so the NMDA antagonists. Many veterinarians and technicians are familiar with ketamine, which has a very, very short half-life. So if we're giving a single IV dose, that's not going to be a good long-term pain protocol, and may have some safety issues depending on the patient's overall health. As a CRI, it can be used for perioperative and sort of short-term in-hospital pain management, often in conjunction with fentanyl and lidocaine. But amantadine is also an NMDA antagonist, which has a much longer half-life. It can be dosed at once a day, so it's quite convenient, and is quite a good long-term option for chronic pain in patients that have a source of pain that either is going to take us an extended period of time to resolve, or one that we may not be able to resolve, or they'll be managing chronic pain for the duration. Amantadine is a good thing to consider adding. It is overall relatively well tolerated. The generic is not terribly expensive, so it's a good option. It does take some time to work, so it may be that if you give it today, you're not going to see the results tomorrow, but for patients that are more so going to be on something for the long haul. It's something to consider adding in, and it's not controlled, so there's not a lot of extra paperwork associated with it. Calcium channel blockers, gabapentin and pregabalin. I include gabapentin here, although the mechanism is debated, but I include it here because there's some suggestion that calcium channel blockade is its primary method of action. It does not affect the GABA receptors, so the name is a bit of a misnomer. Pregabalin works relatively similarly, although I do have some patients that don't seem to respond well to gabapentin. We switch to pregabalin and they seem to improve. Obviously, case by case, pregabalin is going to be more expensive, at least here in the States. Other note about gabapentin, if we're using the liquid, it needs to be from the manufacturer that does not use xylitol. There's a couple of different manufacturers, and there is a concern with xylitol being in some of those to make the product more palatable for human children. And we obviously don't want to give, even in small doses, xylitol to our patients due to its potential toxic effect. So what is the long-term outcome for cavies that have Chiari and Syringomyelia? In this particular paper, there's 48 cavies, variety of ages. They all had Chiari-like malformation and associated pain. That was one of the inclusion criteria. Of those dogs, about 80% of them had Syringomyelia, so these things go largely hand in hand. These patients were treated with medical management only. It wasn't standardized, so not all patients had the exact same thing, but drugs like gabapentin or pregabalin, some dogs had an NSAID, and then the dogs were followed up for an extended period of time, a mean of 39 months, so pretty long time. At the end of the study, about 75% of the dogs were still alive. 5 had died from unrelated causes. 7 of those were euthanized due to severe neuropathic pain. So they're euthanized as a direct result of our inability to manage their pain. Of those dogs, 39 of the 48 that had sufficient long-term follow-up were on medications. Of the dogs that were on medications, 75%, so 3/4 of the dogs undergoing treatment still deteriorated, for some resulting in euthanasia. Nearly 15% had static disease, so maybe the medications helped from the standpoint of at least they didn't get worse, or maybe they weren't going to get worse anyway. Only 10% improved, so medical management having a 10% improvement rate is pretty low, even amongst our more difficult to treat diseases. 6 dogs developed seizures. I suspect that has much more to do with the incidence of epilepsy within the breed, as opposed to being a direct cause of this condition. Also, none of those dogs had EEG or anything else to prove that these self-reported episodes were truly seizures, so it's hard to know if truly 6 dogs developed seizures. So what are our other options? If medical management has a 10% long-term success rate, which is dismal, we need to consider other options. Foramen Magnum decompression is the surgery of choice. There are different ways of doing it and different described techniques. One of the earlier papers describing long-term treatment after surgery was this Claire Rusbridge paper, where they looked retrospectively at only 15 dogs, and all of those dogs had some type of decompressive surgery with an associated durotomy where the dura was opened. 7 of those dogs had a collagen matrix placed there, so not all of the dogs had the exact same procedure, although they were relatively similar procedures. But one of the negatives of it being retrospective is everything wasn't totally standardized. The dogs were followed up for at least a year. 80% improved, 20% were static initially. 47% of those dogs, though, deteriorated at some point post-surgery. Most of those were a couple of years down the road, so at least improved tremendously in terms of their quality of life for a couple of years, but many of them did have some degree of return of symptoms, or at least symptoms that were thought to potentially be attributed to their initial disease. There was post-operative MRI in only 6 of those dogs, and their Syringomyelia was persistent. A slightly more recent paper looking at also a small number of dogs, but a little bit of a larger cohort, 23 cavies, and that were surgically treated with a Foramen Magnum decompression, and then an autogenous fat graft, so fat acquired from that same patient was placed there with a duroplasty of SIS. 17 of those 23 had sufficient follow-up at 3 years, so very extended follow-up, beyond the 2 years or so where they previously reported return of symptoms, had largely developed. Of the 17 that had significant long-term follow-up, 16 of the 17 had great improvements both in their quality of life scores as determined by the owner and also based on their neurologic exam with their overseeing neurologist. So a pretty tremendous response rate. And the other good thing is none of the dogs had any major surgical complications or a significant enough relapse to warrant intervention. So to look at that procedure, these images are from that same paper. We've got 2 images here, relatively similar though. The top left image, R is rostral, C is caudal. So the patient, you're looking down from the top and the neck is flexed. So near R is going to be the external occipital protuberance. And then where you see the V, that's the vermis of the cerebellum. So the hypoplastic and dysplastic occipital bone has been removed, at least the portion that's overlying the vermis of the cerebellum. And then in the next image, same orientation, an SIS graft has been placed there as sort of a duroplasty. And then in the next image, we'll see the autogenous fat graft, which is often going to be acquired from the patient's hip or anywhere else that it's safe to get a large chunk of fat. And then that is going to be placed there prior to closure. The image on the bottom right is an MRI image. Again, it's a from the side view T2 sagittal image. Because fat has a lot of water content, it's very hyper intense. And so you can see where it's marked FG, that's the fat graft, which is sitting there right behind the cerebellar vermis, as it should. So same patient that we saw before, we couldn't even get up the hall without kind of stopping to scratch. We go to her post-operative video. You can see that she's at least able to go for a nice walk. Her gait's not perfectly normal, but she's doing pretty well. She's obviously much happier. Her overall quality of life is much improved, and she's able to walk without having to stop because of whatever sensation she was previously feeling. Briefly, we'll just chat a little bit about the human sort of crossover. Again, the version in people that is most similar to that of dogs is type 1. And in that, these patients, the treatment of choice is a Foramen Magnum decompression. So they don't try medical management ad nauseum. These patients have surgery, even if they've not developed Syringomyelia. So just because that Chiari-like malformation was noted, surgery is indicated. The aim of surgery is to improve the CSF flow such that it's unimpeded or at least less significantly impeded as it exits out the base of the skull. Looking at the statistics in those patients, so the study looked at 177 patients with type 1 Chiari, which is the one that's most similar to what we see in dogs. Again, some had Syringomyelia, some did not. Of these patients, there were a variety of different surgical procedures, but they were all a Foramen Magnum decompression. Some had duroplasty, some didn't. There's significant debate in human medicine about opening the dura because humans do have some potential complications associated with that. We don't experience that in our patients. About half of these patients had Syringomyelia. And then they did follow-up MRI, which is nice. A lot of our studies don't have follow-up MRI, but in humans, they're a little more able to do that. And so about 3/4 of the patients with Syringomyelia had a major reduction. A little less than 20% had at least a moderate reduction, and about 9% there was no change in the Syringomyelia on MRI. But again, that's looking structurally at what's going on the inside as opposed to the symptoms, which all of these patients felt better. This is a similar MRI image to what I was showing you in the dogs, although the orientation is different because it's humanoid. So the cerebellum is at the top of the image, and on the left side of the pane there, you've got the affected patient prior to surgery. So you can see the cerebellar tonsil, which is sort of that caudoventral portion of the cerebellum, which is most similar to our patient's cerebellar vermis. And then after surgery, you can see how much more fluid there is there. And they do a slightly more aggressive approach than we can get away with because they have that tonsil, which can be resected without great symptoms. whereas if we resect the cerebellar vermis in dogs, we would likely have significant symptoms. So our approach is not to resect the cerebellum, but to sort of make more room for it and allow that CSF to pass in an unimpeded fashion. So essentially our approach is the same, or at least the goal is the same. We just get there a bit differently in that we don't resect the vermis because we will get ataxia, dysmetria, and tension tremors and other symptoms that they didn't have before. Whereas in people, the cerebellar tonsil there is a lot more forgiving, and it does seem like they're able to sort of remove and coagulate that with cautery without any major symptoms. Why is there an improvement and then a future recurrence of symptoms, at least based on the first surgical outcome paper that I showed you? It's hard to know. We need more cases that had follow-up MRI. So just because a patient 2 years later developed neck pain, is that truly that their syrinx is getting worse and therefore, they need additional care for this, or have they developed a disc, a tumor, meningitis, etc.? Also, there's the potential for a dural band constriction. It's better described in humans, but essentially it's a band of scar tissue that can form over the surgical site, which can be equally restricting to the spinal fluid as the tissue that was removed that was related to the disease process. So that may be that that's taking a couple years to develop significantly and resulting in that possible 2-year relapse. More information is needed just because many of those dogs didn't have an MRI to differentiate. Is it truly progression of disease? Is it dural band constriction? Or is it an unrelated new neurologic problem that's resulting in the symptoms? So to wrap up, the Foramen Magnum decompression is far more effective for the right patient, and patient selection is certainly key, than medical management alone. In both instances, a cure is often not achieved for these patients, but to maximize their quality of life, patients that are shown to have progressive disease should consider having Foramen Magnum decompression surgery performed relatively early into the course of their disease to result in an improvement in their long-term symptoms and overall quality of life. Again, there is the potential that it would not be curative. For many patients, it's not, but it still improves their quality of life. They may improve and then develop symptoms again in a couple of years. In that instance, a strong recommendation to re-image to determine if it's a true complication versus progression of a disease that we know is relentlessly progressive, or do they have a new symptom that we need to address? Real quickly, we do have our Canine Chiari Institute at 7, and one of the goals of that institute is to identify this condition as early in the course of disease, meaning even before they develop symptoms, both to establish a relationship, start talking about measures of slowing disease progression, informing owners of what to monitor for symptom-wise, and really have a strong relationship to help determine if and when that patient becomes clinical, what the best course of action is. And the earlier in the process we do that, the better the long-term outcome. So by screening them even before they have symptoms, we're catching it, as early as one could. This also has implications for breeding. So for breeders who want to be responsible and determine if their patient, even if their pet rather, is developing this syndrome or has this syndrome, even if they don't have symptoms, if they're going to breed them, they should know, because then we can apply the British grading scheme that I briefly showed you to determine if that patient should be bred or not, and what suitable mates sort of MRI criteria should be. So this discounted program is for patients who do not have any symptoms. So that's an important distinction here. Our Chiari Institute obviously sees both clinical patients that have symptoms as well as these patients who we're trying to catch before they develop symptoms. This particular handout, though, which is attached as one of your reading materials that you should have access to, is talking about our reduced cost screening. So to incentivize developing this relationship early to maximize the outcome for these patients, we do have a $900 kind of flat fee, covers everything associated with the process, the exam with the neurologist, the high field MRI, the anesthesia, and a detailed report with recommendations is all included in that number. Again, this is for those who don't have symptoms. We do MRI and obviously treat many, many patients with symptoms, just the cost is a little bit different because it's not incentivized in the same way. but an MRI is appropriate in both instances. So we've got a few minutes for questions, and we'll pull up here and see what questions have been submitted. If you haven't submitted them, please submit some now. We've got a couple minutes. Okay, one good question. Kara has asked, do we see French bulldogs with syringomyelia? The answer is absolutely yes. So French bulldogs develop syringomyelia. Occasionally, it is due to Chiari-like malformation. However, more commonly, we'll see that their syringomyelia is secondary to the congenital vertebral anomalies that that particular breed is predisposed to. So anything that impedes the spinal fluid anywhere along its path out of the brain and within the spinal cord can result in syringomyelia development. So it is a little bit different in that most of the French bulldogs, it's due to compression from a vertebral anomaly. So whether they have a hemivertebra or something to that effect being the most common example, that will alter the spinal fluid flow through that region, developing syringomyelia. Additionally, they can get sort of a fluid dilation along the top of their spinal cord, which is more of a diverticula. That also can cause a syrinx as well, although the diverticula and the syrinx are two distinct issues and will be managed differently in that the diverticula may need direct surgical intervention as opposed to just restoring the CSF flow through foramen magnum decompression. This would be more so since the blockade is at the level of that sort of diverticular or sort of compressive fluid. That's where they would have surgery as opposed to their foramen magnum like we would do for a Chiari patient. But the behavior of the syrinx is relatively similar, although the presentation symptom-wise is different in that more so in the French bulldogs with syringomyelia, we see more walking issues. They can certainly have back or neck pain, but they're a lot more likely to have weakness, whereas the Cavaliers are much less likely to have weakness, at least as an early symptom. They'll have more of the insidious onset of behavior change from chronic neck pain, the phantom scratching, things like that. Wendy asked, are these issues related or correlated with the characteristics of breed? And in parentheses, it says head shape. If so, are there attempts to have breeders avoid breeding those that have those types of traits? So there are papers looking sort of at the morphology of the skull relative to brain size to use that to help understand sort of where some of the crowding at the back of the brain might come from. However, that can't be used to extrapolate and say, okay, this patient has a more prominent forehead or other external physical features. There's no, to my knowledge, correlation of external features being linked with disease. Some of those morphologic features on MRI could be used to characterize further, but as far as screening patients to determine who should breed and who shouldn't, does unfortunately require an MRI. There's no physical feature that is going to be in any way sort of correlating with either current presence or future development of the disease. Someone asked, this is a good point to clarify, if they heard me correctly, they want to know why syringomyelia patients get worse after an MRI. They don't. So to be terribly clear, MRI has not been known to make a syrinx worse or make the symptoms of a syrinx worse. That's not true. A myelogram, which is a diagnostic technique which we don't use and don't recommend, where contrast is injected to better see the spinal cord on either X-rays or CT scans, that is associated with making the patients worse because of the way the contrast agent interacts with the syrinx. An MRI does not inject any contrast into or around the spinal cord. So there are no patients that I'm aware of that have gotten worse after an MRI. So to be clear, MRI will not make these patients worse. It is absolutely indicated to make the diagnosis. It's minimally invasive. The patients do great. Things to avoid are myelograms, which is an injecting of contrast, which is often paired with a CT scan, which is not a recommended way to make these diagnoses. So good question. Someone asked what the youngest age would be to perform an MRI. I like for the patients to be at skeletal maturity when we're talking about screening, meaning if they don't have any symptoms, I like to do it right around sort of the 10 to 14 month range. Most small dogs' skulls are not going to be changing in size after that age. So for screening for the bony malformation, meaning the Chiari-like malformation, screening them roughly around a year, give or take a couple months, is the great time to do it, because they're young enough that we're catching them very early, but they're old enough that they're skeletally mature. However, if we have a patient with symptoms younger than that, then it's appropriate to image them, as if they already have symptoms, likely we're going to be able to make the diagnosis. And we need to consider, well, what if it's not Chiari and Syringomyelia? Are we missing something else? So if they have symptoms, MRI them when they develop symptoms. If we're talking about screening, then I would screen when we're around 1 year of age. Someone asked about syringoperitoneal shunting. There is a very limited paper that looked at doing that in a couple of dogs with sort of variable outcomes. It's not a procedure that I have performed, mostly because I haven't had a need to. Most patients do so well with the Foramen Magnum decompression surgery, the way that I perform it, which is similar to that second paper with the autogenous fat graft and the SIS duroplasty, that I haven't needed to grasp for some of these other less studied techniques. But there is one paper looking at it where someone sort of tried it in veterinary patients. The outcome, at least in those very few patients, from what I recall, wasn't where we want it to be. I think there's a fair bit of complication. One, because we're now talking about introducing injury into the spinal cord. We now have something foreign that is, obviously potentially movable and things like that located within the spinal cord, which is obviously a very fragile region. So anything with implants like that comes with a little bit more concern for me personally. The Foramen Magnum decompression with SIS fat grafting does not leave any sort of true implant in place, which decreases the associated risk. Although there are different techniques, I'm describing the way that I do it. As far as genetic markers to, instead of doing an MRI, are there sort of gene tests available? Unfortunately, not that are predictive because of the complex inheritance. Although there is a thought to what genes might be at play, it's a bit multifactorial, but also not all dogs with those genes are likely to develop symptoms. So the British Association's grading scheme is thought to be more predictive for planning a breeding than any sort of gene testing at this point. Someone said, can you promote, or rather prevent SM by promoting bone growth through natural remedies? No, so it's not bone growth that's causative here. It's sort of abnormal bone growth. So although it's hypoplastic and there may be less of it, it's often thin. It's angled at an inappropriate sort of way, an inappropriate angle. So the dysplastic component of that occipital bone is probably more causative, at least in the Chiari-like malformation portion of things. So although there aren't many natural remedies that I'm aware of that truly promote bone growth, even if those existed in a reasonable fashion, it would not be a good treatment of choice. Same contributor mentioned that skulls stop growing at 5 months. That may be true for certain breeds. Every dog is different. The recommendation for doing it in the 10 to 14 month range is that we want to make certain that we're looking at a skeletally mature patient and not to have to interpret wondering whether it's skeletally mature or not. Last couple questions. Someone asked about laser, acupuncture, physical therapy. All great things to consider. The truth is we don't know the efficacy of those conditions on this population of patients. Physical therapy across the board, if they have any mobility issues, is a stronger recommendation. Things like laser and acupuncture are debated a bit. Truth is we don't know. for patients where traditional techniques aren't helping, I'm not opposed to those things being trialed to see if they do indeed result in improvement for that particular patient. But as a broad treatment recommendation, particularly not in isolation, I would not. Last question here. Someone asked, how long should we use pain medications in the cases of medical management? The person submitting the question says they like to use gabapentin for life if the patient remains static. So I think it all, just like the surgical versus medical management decision and the timing of each of those are patient dependent. So what works for one in such a dynamic disease isn't going to work for everybody. And what works this year may not work next year for these patients. So similar to epilepsy and other chronic diseases, we have to tailor what we do to each particular patient. And what works for one won't work for another necessarily, and what works now may not work later. So as far as initial pain management, first question is, do we have a diagnosis? Ideally get a diagnosis before we do too much for too long. Second, if we have a diagnosis, how symptomatic is that patient? If they're terribly symptomatic, well, we're probably going to use things other than just gabapentin. If they're very mild cases, gabapentin alone is a very good choice. I would always use omeprazole in conjunction with whatever other therapy is employed to try to slow the progression of the syrinx by reducing spinal fluid production. So is gabapentin and omeprazole long-term reasonable therapy for those who have very mild non-progressive symptoms? Potentially so. If they have more significant symptoms, we may start a couple of medications up front to get them more comfortable, and then try to wean down to only 1 or 2 long-term medications, with gabapentin almost always being one of the long-term medications, in conjunction with omeprazole to actually try to slow the underlying progression. There were a few other questions that were either particular to a single patient or previous patients saying hello. Thank you for that. And we'll respond to those individually as we are out of time. But thank you all for coming. If you have other questions or things that I didn't address, feel free to reach out. We're glad to chat with you. And like I said, for those last few questions, I'll entertain those privately through email. But again, thanks for coming. Please fill out the survey at the end. You know, we do this for you guys, so let us know what we can do better. If there's other topics that you want that aren't on our current agenda already, or a different format that you would prefer, or anything else, fill out that survey and provide that feedback to us so that we can improve for you. And you'll get your CE certificates by email within an hour or two. That will happen automatically. You shouldn't need to do anything. If you're registered, you'll get that sent to you. Thank you so much.